And finally, I just want to say that this is a Dr. Lawrence H. and Roberta Cohn forum, and we're deeply thankful to them, and we want to recognize their generosity. So thank you so much. And with that, it is my pleasure to welcome Harvard Chan PhD candidate Bailey Bowcutt and Dr. Anthony Fauci to the Harvard Chan studio. Thank you.
Hello.
Hi. All right, welcome everyone. I'm Bailey Bowcutt. I'm a third year PhD student here at Harvard T.H. Chan. I'm in the Biological Sciences and Public Health PhD program, and I'm studying antimicrobial resistance here. As a public health student and researcher, I am especially honored to be joined by Dr. Anthony Fauci, physician and distinguished university professor at Georgetown University in the School of Medicine's Department of Medicine and the McCourt School of Public Policy. I'd love to one day become a public health servant, and I appreciate you taking the time to guide us students as we follow in your footsteps.
Thank you.
Yeah, thank you so much for being here today.
Good to be with you.
Also in our audience today are special guests, Mrs. Roberta Cohn and her daughter and son-in-law, Mr. and Mrs. Leslie and Stephen Bernstein. This event is part of the Dr. Lawrence H. and Roberta Cohn Forum series. So thank you to them for being here today. All right, I'm really excited, so sorry if I speak fast here today. But before we get started, here's some background on Dr. Fauci. As I stated, Dr. Fauci served as a physician, a researcher, and an advocate for patients with HIV/AIDS, and later as the director of the National Institute of Allergy and Infectious Diseases. Furthermore, he helped direct the U.S. response to HIV/AIDS, including the PEPFAR program, or the President's Emergency Plan for AIDS Relief. Dr. Fauci has advised administrations of both parties over the decades, helping guide the country through health concerns such as the anthrax attacks, influenza, Zika, Ebola, and the COVID-19 pandemic. I recently read Dr. Fauci's memoir, On Call, A Doctor's Journey in Public Service, which takes us through his 50-plus years of leadership. As a heads up, I've based many of my questions today on that book. I would recommend. But we'll start with some questions from me, and then today we're going to end with some questions from the community, from our students here.
Okay.
Okay. So I wanted to start us off with an icebreaker. You have the option between two questions. The first one is, why are the Red Sox better than the Nationals, your favorite baseball team? Or what is your favorite microbe?
My favorite microbe. Well, I'll answer both of them. The Red Sox, except for 1 year when the Nats won the World Series, have been substantially better than the Nationals, for sure. Our fans are not as passionately crazy as the Boston fans are. But anyway, when you ask the question, Bailey, of my favorite microbe, it's a difficult question because when you say favorite, like they're my friend and I like them.
Yeah.
The one that I've spent 44 years and 3 months on has been HIV. So certainly HIV, I wouldn't say is my favorite microbe, but it's the one that has been my professional companion for, almost a half a century. So that's the answer to that.
All right, well, that's a really great segue into the next section, actually. So on a more serious note, what inspired you to pursue your career as a physician, and in particular to focus on HIV and AIDS?
Well, to pursue a career as a physician, you have to go really back to my childhood, I think. I come from a family, my parents my father was a pharmacist in a working class section of Brooklyn, New York. And back then in the 40s and 50s, the pharmacy was not the industrial pharmacy that you have today. The pharmacist was kind of the neighborhood psychiatrist, marriage counselor, and comforter of parents who had delinquent children. And the neighborhood that I grew up in, that was a very common occurrence. So he cared about the community, and I was in there delivering prescriptions on my Schwinn bike when I was 8, 9, 10 years old. And the fundamental atmosphere that during my developmental years, was one of serving the community. He was a very poor businessman. Let me explain. Most of the people who were not financially well off enough to be able to pay for their prescriptions, he would say, don't worry, put it on a bill and you could pay later. And many of them did not have the financial to do that. So his only concern was taking care of the community. So that was kind of in my DNA from the very beginning, that it's really important to be caring for people and serving people. I had no idea I wanted to be a physician then. And then when my education, by the circumstance of the education I had, through Catholic schools with the nuns who teach you some tough love and that. And then I had 4 years in a Jesuit high school and 4 years in a Jesuit college, Holy Cross, just, 40 miles west of here, whose theme was service for others. So when I started to think about science, I really liked science a lot, but I was as drawn towards the humanities, feeling that I cared a lot more about people than I cared about anything else. So I said, if we got scientific propensity and passion for it together with really caring about people, it was the natural thing in the world for me to go into medicine. HIV, is that the next part of the question? Yeah. HIV, I think for the students and the postdocs and others in the audience, was really a classic example, as I've described, of the essentially lack of linearity in one's career. And that really is very true for me. By lack of linearity, I mean you could kind of plan a linear course of where you might want to go, but things arrive, circumstances almost always beyond your control, that provide an opportunity that you never would have anticipated. And that's when you've got to look at it and say, is that something that might even be more suited to me than the one that I aimed at? So when I went to medical school, I was absolutely fixed on what I wanted to do. I wanted to do an internship, a few years of residency, a chief residency, and I wanted to do a fellowship in a subspecialty. And the thing I went to Cornell Medical School, the New York Hospital Cornell Medical Center. I did my medical school there, my internship, residency, and chief residency. And my goal was to come back to New York City and practice medicine at the New York Hospital. And I wanted my office to be on 71st Street and First Avenue. So I knew exactly what I wanted to do. But then when I went down to the NIH for a fellowship in infectious disease, they had a combined fellowship of 3 years. You get board certified in infectious disease and in clinical immunology, but you also have a lot of, 2 years of bench time. So I did research only for the qualification to come back and practice medicine, and I fell in love with the concept of research in doing something that would have an amplifying effect, that if you made a discovery or developed a protocol, it would go well beyond just the individual patient that you could take care of, even though I always was committed to continuing to see patients. And I did that I finished my chief residency in 1972. And I was very fortunate. I had a really generous mentor, again, lessons for pre-doc and post-docs. Pick a really good mentor, somebody who really cares about you. He put me on a very interesting but high-risk project, which is a little iffy when you're in your early years. Do you really want to do a high-risk project? But it was to develop therapies for formerly fatal autoimmune and autoinflammatory diseases, the vasculitides, what we know now as granulomatosis with polyandroitis. So at a very early age, immediately following my chief residency, I was like 29 years old, we started a protocol that took a disease that was formerly fatal, and we developed based on a modification of cancer chemotherapy at a very low dose, inducing regimens that induced a remission rate of 93%. So we went from 100% mortality to 93%. So I was really lucky. I think I was pretty good, but I was also lucky that I had this situation where my project exploded. So at a very young age, I became quite well known in medical circles. From 72 to 81, we put out protocols. Everybody was using it throughout the country and the world. But by the time we got to 1979 and 80, what I was doing seemed to be more incremental than transformative. And even though what I did from the 72 to 77, 78 was, game changer, I started to say there's got to be an even broader challenge. I had no idea what that would be. Then in 1981, this MMWR landed on my desk reporting 5 young gay men from Los Angeles with a strange pneumonia that I was very familiar with because I had my boards in infectious diseases. I was seeing a lot of infectious disease cases as a consult, even though my basic bench research was immunology. I was clinically an infectious disease person. So I saw these cases and I said, boy, this is unusual. Why are all gay men and why were they previously healthy and why pneumocystis? I put it aside, thought it was a fluke. 1 month later, in July of 1981, the next MMWR landed on my desk. Now, 26, curiously, more than curiously, amazingly, all young, previously healthy gay men who presented not only with pneumocystis, but with other opportunistic infections and Kaposi's sarcoma. And, it was the first time, and, not the only, but close to the only time in my scientific and medical career that I looked at it and I actually got goosebumps. I said, oh my God, this is a brand new disease. Like, whenever is there a brand new disease? And it's has to be infectious epidemiologically. We didn't know what the etiologic agent was until 3 years later. We didn't even have a name for it. We're calling it GRID, gay-related immunodeficiency. So I did something that, to me, I had to do it. It was sort of like my gut told me I had to do it. I put aside this very successful career and made another pivot and handed my inflammatory disease thing to my trainees and said, you do it. And I devoted, starting in the summer of 1981, all of my time to studying this terribly devastating disease in which we didn't have an etiologic agent. And I started that, as I said, in the summer of 1981 for a number of reasons. I felt it was a challenge that I couldn't walk away from. I knew it was an infectious disease. Epidemiologically, it had to be. It was sexually transmitted. The epidemiology told you that. And it was destroying the immune system. And here I am, a guy who's got his boards in infectious diseases, his boards in clinical immunology. It was almost like if ever there was a disease that I should be studying, my mentors, who were wonderful, actually thought I was crazy to do that. They said, what are you doing? The career trajectory is like this. Why are you studying a disease that's going to go away? This is a fluke. It's not going to amount to anything. So I stuck with it, 44 years and 3 months later, 44 million people were infected, and many, many died. Anyway.
To continue to speak on HIV, there have been some exciting developments in HIV treatments in the past year, including promising progress towards a medication that could be taken just twice a year, and early proof of concept of a vaccine, although there's been some other issues with past vaccine proposals. Where do you see the field headed, and do you think it's possible to eradicate HIV?
So you've got to define the word eradication.
Yeah.
So if I said this, don't quote me on this. We've eradicated one disease in the history of mankind, and that's smallpox. So when you use the word eradication, that means that nowhere in the world is this microbe. We did that with smallpox through a lot of a phenomenal implementation of a combination of vaccine, not the whole population, but vaccine, ring vaccination around cases. There's another terminology called elimination. And elimination is what we've done with other diseases like no longer present in a certain region. So right now in the United States, malaria has been eliminated. Measles has been eliminated. We could talk about measles in a minute, but measles has been eliminated. Polio has been eliminated. All diphtheria has been eliminated. So if you're asking me, are we going to eliminate it? I don't think so. I think there's so much disease out there. But what you can do is you can end it as an epidemic, a pandemic, and you could very well control it, which gets to what you're asking, which is an interesting problem that gets into the disparities of health accessibility in some sections of our own country, as well as in the world. And that is and I'm telling you things you probably already know, but you might as well hear it from me, is that if you look from the scientific standpoint, we always need better science, because if we didn't have fundamental basic science, we wouldn't anywhere near where we are right now with the tools that we have with HIV. But when I was taking care of persons with HIV from 1981, 2, 3, 4, 5, 6, it was the dark years of my medical career, because every one of my patients, with very few exceptions, died. So I went from this hotshot who was developing protocols that were making a formerly fatal disease, now 93% remission, to everything I was doing, sooner or later they would wind up dying. Then we developed drugs, first one drug, AZT, in 1987, then 2 and 3 drugs in 1996, triple combination anchored by the protease inhibitors. And then as we got closer to 2000, we had one pill with 3 drugs in it anchored by the integrase inhibitors that did something we never would have imagined. And again, for those of you who are involved in that, you know what I'm talking about. If you get the level of virus in a person living with HIV to below detectable, you save the life of that person, and you make it impossible. Now, a scientist should never say impossible, but you make it virtually impossible to transmit that virus to somebody else. So hang on to that. So theoretically, if you could identify everybody who's already living with HIV and get them on a proper antiviral therapy, you could essentially eliminate, maybe, but certainly control HIV. Superimpose upon that pre-exposure prophylaxis, which with one pill a day, if you give to an individual and they actually take that pill every day, it's a 99% efficacy in clinical trials. The difference between efficacy and effectiveness, efficacy says you can do it, effectiveness is if you do it. And the efficacy is 99%. Now we have injectables that if you give lenacapavir, which is a capsid inhibitor, give lenacapavir twice a year, every 6 months, in 2 studies, Purpose 1 and 2, you have 100% efficacy in women and then a 96% efficacy in men and transgender individuals. So if you identified everybody that's at risk for infection, and well, how do you know if you're at risk? You could tell by what the special populations are. Young women in South Africa at a high risk. And you give them lenacapavir twice a year. So you treat those who are infected, living with HIV, and you give 95 to 100% protection for people who are at risk. You could actually eliminate, at least in certain regions. You're never going to eradicate, but you can well control it. Which brings us to another important issue we're facing now, is the reason that's not happening is because of the profound disparities that we're seeing globally in healthcare, which is the reason why, despite what some people are saying, global health is still important. Okay.
Well said. All right, next I want to talk about trust and a little bit about criticism. So early on, HIV activists criticized you, but you developed a rapport with them, and over time you grew to be perceived as an ally. Could you talk about how you built trust with this community? How do you balance responsibility to uphold good science with the equally important responsibility of listening to and collaborating with community voices who may be skeptical of your efforts?
Yeah. Well, that's a great question. I'm happy to answer it, but I also want to add a little twist in it because people sometimes look at the pushback on the part of predominantly the gay community in the mid to late 1980s and into the early 1990s against government. And what we're seeing now with the pushback against science. And people say, well, they pushed back then. You were criticized for a number of things, and I'll get into that. And they're pushing back now, and you're not only criticized, you're vilified by it. Are they the same? Well, you talk about the difference between apples and oranges. This is the difference between peanuts and elephants.
Yeah.
It's totally different. And let me explain. The gay community back in the 80s were in a situation where the federal government, well-meaning, and when I say federal government, I include myself because I've been a federal scientist and a public health person, the federal government and all of my scientific colleagues, some of which some of which are not in the business anymore, felt that if you're dealing with a disease from a scientific and from a regulatory standpoint, you go with what has worked well for other diseases. Namely, you have clinical trials that have very strict entry and exclusion criteria so that your data are pristine. It's not complicated. The data are incontrovertible. That's the first thing. The regulatory community, the FDA, says we have protected the American public and we have great medications for heart disease, for cancer, for hypertension. So when we approve a drug, it takes 5 to 7 years to finally get all the data to approve it. There was nothing wrong with that. What the gay community was saying is that this is different than that because from the time you were symptomatic, now it's different because you get tested for HIV, you're on therapy before you get any symptoms, and you never get sick. Back then, when you were identified as living with HIV, you had 12 to 15 months to live. That was your life expectancy. So they were saying, do the math. You're telling me wait 5 years for something. There has to be a compassionate availability for drugs, and you have to have some mechanism. If the only accessibility of getting on a clinical trial, the only way you have accessible to an experimental drug is on a clinical trial, but the clinical trial is taking place in San Diego and in St. Paul. We're living in Boston and New York, and we don't have any accessibility. You got to be more flexible. So the federal government scientists said, we understand, but we're scientists, we're regulators, we know what's best for you. Boy, that sounds, I get VPCs when I say that. but it's the truth. That's what they said. And what the gay community said is, no, we want to be part of the process. We want our input into what you do. We want a seat at the table. And only when the scientific community essentially would not listen to them because they said, you're not a scientist. We know what's best. We'll take care of you. We do care about you. They became iconoclastic, disruptive, theatrical. And since I was the face of the federal government, because I was one of the few people, now remember, go back, this is in the 1980s. I was one of the few people that was out there seeing patients, trying to get more resources for HIV. They started to attack me. And one of the best things that I ever done in my career, professionally or otherwise, is instead of focusing on the theatrics and the disruption, which most of the scientific community did, the more they demonstrated, the more they withdrew, because they became the enemy. I said to myself, let me listen to what they're saying. And when I listened to what they were saying, they were making absolutely perfect sense. And I said to myself, if I were in their shoes, I would be doing exactly what they were doing. And they were doing some rather provocative things. They shut down Wall Street. They invaded St. Patrick's Cathedral. The Monsignor almost had a heart attack. They had to resuscitate the guy. And we finally, I said, let's talk about what you need. And we did that over a period of time. And those, as you said in the question, those activists who were disruptive became a permanent part of the discussion of how you design a clinical trial, of how you have accessibility. I mean, we started something called Parallel Track, which was actually that you don't interfere with the clinical trial. You have strict entry and exclusion criteria, but there's another pathway to get access to a drug by compassionate use. There wasn't compassionate use before then. So if you weren't in a clinical trial, you didn't have a chance. Now we were able to do that. So they were completely right in their demonstration. That is different than the normalization of untruths and conspiracy theories and crazy things that are going on now that I don't need to explain to you. Turn your television on or go into social media and you'll see it. A lot of people, you know, they kind of say they're similar. They're not similar at all. They're really, really different.
Yeah. One is fighting for your life and one is conspiracies.
Yes.
Yeah. Speaking of things with threats and challenges of today, there are many current threats to public health and biomedical research. We feel them very intensely here at Harvard Chan School. Could you share how you're thinking about this in the moment? What are your biggest concerns? And how can we as public health professionals try to address them?
Well, you know, I'm fundamentally a cautious optimist, historically. Right now, I'm a really concerned, cautious optimist. And let me explain. I think you know where I'm going on that. You know, we are under assault. I mean, I think right here, you know, at Harvard in general, and at the School of Public Health specifically, that we're dealing in very, very difficult times. What one can do about it is, to the extent possible, push back on the misinformation and disinformation. Do not accept the normalization of untruths as something that's normal. Because when people get discouraged and throw up their hands and say, well, what are you going to do? You know, social media, they just spout out these things that are absolutely untrue, from things as ridiculous that COVID vaccines have killed more people than COVID. I mean, the data doesn't mean anything. And when people say that and it gets amplified on social media, the people who are not like us, who do it for a living, they see that, and when you normalize untruths, then no one knows what true is really true. And guess what? When you look at history, when that happens, that's when democracies fall apart, when there's no truth there. So anybody can say anything. So what's the solution to that? The solution is that we, certainly, you know, me at my age, but more importantly, the audience at most of your age, you can't give up and you can't get discouraged, because the people who are spreading the misinformation and disinformation that is attacking the importance of global health, attacking the importance of equity and accessibility to care, they're very, very energetic on social media. In fact, I actually think they don't have day jobs. That's all they do is that. And when you ask other people to counter it, you're really asking people who are really very busy, like yourself. I mean, you're trying to write a paper now, right? So you're going to really waste your time trying to counter that. But you really have got to not accept things that are just nonsense and say, well, that's the way life is. That's not the way life is. That's unfortunately what's going on right now. But that's really abnormal and an aberrancy. And it can't sustain itself. It can't, because that kind of stuff is unsustainable unless something really catastrophic happens, like the democracy falls apart. And we can't have that.
Yeah. You said that in your years at the NIAID and advising for the White House, as well as your time over many presidential administrations, you sought to stay politically neutral. I'm interested in how you went about that, but also we all saw the politicization of public health during and after COVID. In our hyper-partisan age, do you think it's still possible and desirable for public health officials to strive for neutrality?
The answer is absolutely yes. And what you are doing with your lives and your career is a statement of that. And let me explain what I mean. So I tell the story in the memoir, but I'll tell it to the group if you haven't heard it, is that the first time that I was asked to go into the White House to brief President Reagan in the 1980s. I know you're looking at this guy is so old. What is he doing? He's still sitting up straight. So I was going into it to brief him, and my message was going to be that I like the guy, and I think he did some good things. But he did not use the word AIDS in any public speech until the second year of his second term. So he was elected in 1980. He was inaugurated in 1981. And 5 months later, the first cases of HIV, which would ultimately be HIV, were reported in the MMWR that I told you about. That was 1981. It wasn't until 6 years later that he mentioned he lost the opportunity cost of using the bully pulpit of the presidency to call attention to an emerging outbreak and to put the kind of resources in there. So anyway, getting back to what I said, when I was getting ready to brief him, a friend of mine who had a conservative Republican friend of mine who worked for 6 years in the Nixon White House, trained right here at Boston City Hospital, was a surgeon, went to Boston Latin High School, good guy. He told me and gave me some advice that I would have hoped, and I think I would have come to that conclusion anyway. And what he said as I was getting ready, I said, I'm going to see the president tomorrow. He said, let me give you some advice. He said, any and every time you go into the White House and walk under that awning of the lower level to get into the West Wing to advise a president or his or her associates about anything, whisper to yourself, this might be the last time I'm walking into this building because I might have to tell the president and his or her associates an inconvenient truth that they may not like, and I might not get asked back. And what do you mean by that? Because the White House is a heady place. And when you go in there, here's where Teddy Roosevelt was, and Franklin D. Roosevelt, and John Kennedy. You get the instinctive feeling it would really be great to get asked back. And there is that danger that you might tell somebody something that isn't scientifically correct because you didn't want to upset them and you didn't want to be the messenger that gets shot. And his advice was, always tell the truth, always be transparent. And if you don't get asked back, at least you have your integrity, and that's much more important than getting asked back. So through 7 presidents, I did that. I had to tell people things that were inconvenient truth. And as a matter of fact, I've been to the White House now hundreds and hundreds of times. I spent 1 year during the Trump administration and 2 years with President Biden, because there is a feeling when you're a scientist, it doesn't matter. I have advised George H.W. Bush. We developed the PEPFAR program with George W. Bush. I was very close with President Obama and President Clinton. And it doesn't matter whether you're a Republican or a Democrat. I am not a political person. I'm a scientist. So you're asking the question, Bailey, how do you do that? Just remember who you are. You're a scientist, and science itself is not a political thing. It's facts and evidence and data. So to be honest with you, it sounds tough, but it's easy to negotiate. All you have to do is remember who you are. And it doesn't matter whether you're dealing with a Republican or a Democrat or somebody else. Just remember who you are, and you'll be fine.
That's awesome. Thank you. Now I wanted to share some of the questions from our community. So thank you to all of the students who submitted questions for today. I wanted to end on a question from Victoria, who's a student here. What advice would you give to your 25-year-old self?
Well, when I look back at my memory doesn't go back that far. No, just kidding. Is that I am not, by any stretch of the imagination, the poster child for a good, healthy work-life balance. And I think it's just a combination of my personality and the situation that I found myself professionally thrust into during the early years of HIV, when you were working 18 hours a day, every day, including Saturday and Sunday, because these patients were so sick and you were trying to do some research. So if I had to do it over again, even before 25 years old, is that when you're young and trying to establish yourself, there's a lot of stress associated with that. So remember, back then, nobody knew or cared who I was, okay? Just like, with all due respect, probably many of you, nobody knows or cares who you are,
Yeah,
except the people you love and who love you. I'm talking about the general population. And, in striving to succeed, I think you put a lot of stress on yourself. So if I were to go back and say, what productive result was it from all the stress I put on myself? I probably didn't necessarily make myself much better by always feeling stressed about things. So I wouldn't have done any experiments differently. I wouldn't have done any choices in the direction of my career, but I would have liked, the 80-plus-year-old Tony Fauci to whisper down to the 25-year-old Tony Fauci, chill, man, everything is going to be okay.
That's great advice. Well, thank you so much for joining us here today. And I want to thank you for taking the time to speak with us about your interests and the wisdom you gained over your career. It's really been a joy. And I think there can be so much joy and fulfillment that comes from a career focused on helping others, even when facing adversity. So thank you for reminding us of that.
You're welcome.
Thank you.
Thank you.
Thank you.
Thank you.